Here at Transformations Care Network, as the Chief Medical Officer, I do carry the torch of the interventional service line. That is my subspecialty. It's where my passion lies. It's what I had done many times over in the years following residency. Interventional psychiatry includes a couple of different procedures, one of which is kind of well established but highly stigmatized at this point, called ECT. The newer age version of that we now often use in the outpatient setting is a treatment called TMS. TMS is nothing like ECT, other than it does share some similar scientific background in that both of them use energy to turn on the brain. And as a TMS specialist, I will tell you that TMS, or transcranial magnetic stimulation, will often achieve results in the 80+% range for remission and or response. When you look at where we are or have been with our standards of care to this point, using medication, Prozac, Zoloft, Effexors, plus things like CBT therapy, DBT therapy, when we look at that package together in some of the largest studies in mental health, we know that by the time you hit your third medication step edit, your chances of achieving remission drop to less than 15%. Compare that to transitioning over to TMS at 80+%. We are truly at an order of magnitude better. So here at TCN, I not only carry the torch as the CMO for interventional services, I carry the torch of what our standard of care must be in order for us to achieve different results into the future. And the reality is, if we don't start achieving different results than 15% success, we will not get better as a community, will not get better as a country. One of the ways we can do that is through TMS. If I'm going to hand someone their third medication and provide them a 15% chance of remission compared to 50, 60, 80% on TMS, our standard of care is TMS. It is best for the patient. It is best for the provider. We raise our standard of care around the data and the science, and there is no question that that is heavily skewed towards interventional at this point in time. So as we discuss raising our standard of care through treatment options like TMS, we often get asked the question, what does that mean in terms of side effects? What does that mean in terms of risks? So let me first go back to the STAR-D data. I alluded to it earlier. In the STAR-D study, by the time you hit your third medication edit, you have a 15% chance of achieving remission, and you also have a nearly 35% chance that you'll stop the medication due to side effects. Side effects from traditional medications are systemic. They are head to toe. They often involve stomach issues, skin issues, headaches, sexual side effects. What's interesting or unique about TMS is it's very specific. It is non-invasive, but it's highly targeted. We're literally treating an area of the brain that's about the size of a quarter. We're energizing that area of the brain, flicking the dominoes so that the rest of the networks start connecting and the brain starts functioning again. What we know about depression is if we look at someone's brain who's depressed, it's often underactive or disconnected. And so again, by using energy focused at that point, we know that that's the domino effect for turning on that network. So that is very focal. Now, if you've ever had an MRI before, if you ever heard that clicking sound, TMS uses electromagnetic energy. So it uses a magnetic coil, not dissimilar to an MRI. And so if you've heard that clicking sound before, you would hear that same sound as part of this treatment. That sound also creates a wave or a pulse that can be felt on the forehead, which is the area just north of the forehead, the area that on the head that we direct the treatment toward. So there can be some mild scalp discomfort as part of treatment. And again, because of the noise, we want to make sure you have ear protection, as the noise could cause, without ear protection, could cause some sort of hearing damage. But under the right safety guidelines, the right ear protection, the right treatment location, the risks of TMS are actually very, very minimal. So as we think about how we raise our standard of care, and more importantly, how we get the awareness out there about these standards of care, we have to think about how we engage our patients day to day who might not yet be a candidate for an interventional process, TMS, Spravato, ketamine, but who statistically may end up there. And that includes engaging the patient earlier in the process so that they have their own autonomy to make the appropriate decisions around the data that we know to be true. Even though TMS and Spravato are often approved by insurances at step edit number 3 or number 4, the reality is the APA, our governing body, actually slots in TMS as treatment option number 2. So if you have tried and failed Prozac, Zoloft, Lexapro, Effexor, Wellbutrin, and by the way, failed could include not being able to tolerate those, the APA says you actually are, it's just as safe and just as likely to be effective to go right to TMS at that point. So although most insurances may not cover before you've at least tried 2 or more medications, it doesn't mean we shouldn't start having the conversation with you as a patient or with a patient as a provider so that they understand what options they have. As we think about informed consent with a medication, you also should be informing the patient of what their treatment options include, and that must include the idea of things like TMS, Spravato, and ketamine, and frankly, in the near future, psychedelics like MDMA and psilocybin. When we talk about interventional psychiatry, it really got its label from the idea that it is more procedural based than traditional psychiatry. If you think about psychotherapy as talk therapy, you think about prescribing medication as what we call E&M services or medication management services. Those are less procedural in basis. If you think about being a surgeon is very procedural. Whether you're a cardiothoracic surgeon doing heart transplants or whatever the case may be, the point is interventional psychiatry points to the fact that there is a procedure involved as compared to a prescription or therapy service. Now, it doesn't mean you wouldn't or couldn't do a prescription with an intervention, or you couldn't do therapy. In fact, you probably should do therapy with an interventional service, as it's a moment in time when your brain is the most fertile and malleable and therefore the most likely to process and integrate and improve and stick with better habits. But the reality is interventional got its name from the idea of being an actual procedure. So with TMS, it's using electromagnetic energy to turn on the brain. We're doing that with a TMS system. With Spravato or ketamine, ketamine we do as an infusion process, again, a procedure in nature. Spravato is an intranasal treatment, although a little less procedural, still requiring monitoring and observation. So interventional got its title or framing or name from the idea of not just being a prescription or therapy, but being more of a procedural-based treatment. That's also where things like ECT lie or vagal nerve stimulators. And again, it's also what we will likely slot in or where psychedelics will likely slot in, given the nature of the observation and the treatment itself.